Well, thank you very much for joining us today on another episode of the Domestic Preparedness Journal podcast. My name's Andy Roszak. I'm very excited to be talking about hospitals and in particular Hospital Incident Command as we're here in the era of coronavirus. Now, many of us know that Hospital Incident Command is certainly not something new. It's been around since the 1980s when it was the Hospital Emergency Incident Command System, if you can remember back to those days, and certainly been updated throughout the years. Probably one of the biggest updates, 2003 under Homeland Security Presidential Directive number 5 under George W. Bush, of course, after September 11th. And Hospital Incident Command continues to evolve to this day and is certainly at the forefront when we're starting to think about coronavirus response and how hospitals and healthcare providers are responding. So I'm very, very happy to have this conversation joined by two really good experts. I'll let them introduce themselves in a second. But really happy to have you. So Dr. Brent, I'd love for you to say a few words and talk about your background, introduce yourself to folks, and then we'll go over to you, James.
Sure. So my name is Brent Kaziny. I'm a pediatric emergency medicine physician at Texas Children's Hospital. So I work in the ER at our 3 freestanding children's hospitals. Kind of by way of the way that I found myself in this world, I was an intern in New Orleans during Hurricane Katrina and lived through that experience. I was in the hospital for about 5 days after the hurricane made landfall. And really since then have devoted my career to kind of improving pediatric disaster preparedness and response. At Texas Children's specifically, I serve in the role of Medical Director of Emergency Management, in addition to the work that I do in the Emergency Center.
Well, thank you so much, Brent. And James, can you introduce yourself to the crowd here?
Yeah, very good. So I'm James Mitchell. I'm the Director of Organizational Resilience at Texas Children's. I've been doing that for just this month will be 5 years. Organizational resilience at Texas Children's encompasses business continuity, emergency management, as well as enterprise risk. Prior to working at Texas Children's, I was actually not in the healthcare industry. I was at British Petroleum for 3 years, doing work in IT disaster recovery and crisis management. And then I spent 13 years before that at Invesco in the investments industry, again, doing IT disaster recovery, crisis management, and IT service management. And so a lot of people, when looking at that career progression, think, okay, well, how did you go from one thing to another? And these things actually all flow together very nicely. As most of you can imagine, technology tends to be the driver for a lot of crises. And so a lot of involvement in the technology world and understanding the ramifications of critical technologies and so forth, and just flows right into management of a broad scale crisis within a healthcare organization.
Well, I certainly appreciate both of you being here today and the wonderful backgrounds that you have. James, if you don't mind, I'll kind of jump right into it and start with you, especially because of your cross-sector experience. You know, I know working in all these different sectors, a lot of times emergency management kind of struggles to get recognized, get its voice, get engagement from other departments. And unfortunately, as we see, it's not really until a big emergency or disaster occurs that sometimes people even realize that we have emergency management and incident command. So I'm kind of wondering with your lens of corporate America and now healthcare and everything else, what is kind of your experience? What is incident command? What does emergency management look like prior to an incident? And what are some of the ways that you got some engagement so folks knew who you were? You know, we always say don't exchange business cards during the disaster. How have you been able to engage folks, get them interested, and get them to know who you were before an incident did occur?
Well, I think it is quite fascinating when you look at it across industries. So looking at it in the world of investments and looking at it in the world of the energy industry, emergency management and crisis management tend to fall either into the facility side of the organization or they fall under the technology side of the organization. And so the thing that you struggle with to get your program noticed and get the attention that you need is people tend to silo you into, oh, well, you're just technology or you're just a part of facilities. The most fascinating thing I think about doing this work in healthcare is the fact that we're required to use the incident command system. And the fact that we're required to use it, we're required to do drills around it, is one of the things that, quite frankly, makes healthcare very effective when it comes to managing crises and managing emergencies. And so I think that requirement from a regulatory perspective that you use the incident command system is one element that makes it really effective. But particularly at Texas Children's, the fact that emergency management is, interestingly enough, located inside the risk management department gives us a whole other lens and perspective on addressing a wide range of risks for the organization rather than being siloed into facilities or technology.
Oh, that's a good point. So kind of where you sit in the organization can kind of help frame some of these issues. And I do, gosh, just saying that and reflecting on your remarks, I know a lot of these times they get buried underneath IT or maintenance and things like that. And I guess maybe that kind of sets the stage right from the very get-go of what you can and can't do or what the perception is of your abilities.
Well, it does. And there's a couple of other fascinating things about how Texas Children's operates that makes it a strong program. On the one hand, we have our Emergency Management Committee, which is a committee of people that Dr. Kaziny and I co-chair, and it is made up of roughly 40 to 50 operational directors from within the organization across different lines of business, across different services, across different geographies, that typically meets on a monthly basis to talk about preparedness, to talk about the things that need to be improved and need to be developed. So that's one element that makes us really strong because it's extremely multidisciplinary. But the other thing, and to my knowledge, no other hospital has this, we actually have a dotted line up to an operational executive vice president with whom we meet on a quarterly basis to talk about at the various highest levels of the organization, what are we doing, what are our priorities, and what do we need to be successful?
Well, getting that buy-in from senior leadership, of course, is key. So that's a really great structure that you have there, and I'm sure it serves you well. For folks who are not as familiar with Texas Children, you guys are massive, right? You've got a lot of campuses, a lot of employees. Give us a sense of some of the scope and scale of how big you guys actually are.
I think that's an interesting point because I think, Andy, a lot of times what happens is we hear Texas Children's Hospital and you think Texas Children's Hospital, but it's really so much more than just a hospital. It's an entire system. And that's something that, in James's tenure here, he's seen a lot of that evolution take place. And a lot of that started even before I came back here 8 years ago. And it's just continued to grow and snowball since we've been in this position and doing the work that we've been doing. I mean, right now we have 3 freestanding children's hospitals. We have a pavilion for women. We have a large network of urgent cares, a large network of general pediatric practices, outpatient subspecialty clinics, even positioned as far north as in Austin with subspecialty clinics serving the Austin community, as well as a health plan. So we have our own Texas Children's Health Plan that serves a large number of children across the kind of eastern side of Texas as well. So it's a massive undertaking. I probably forgot something in there somewhere in there, and James can fill in the rest because it just keeps getting bigger and bigger. And so I think, a lot of times we see the logo, we hear the name Texas Children's Hospital, and it really pigeonholes people into thinking about just a hospital. But we've really been tasked with thinking about these things for the entire institution, the entire system, which is, I think, a tremendous amount of work.
And Brent, as far as getting that management, that administration side to buy in, of course, that's obviously important. I'm curious about your reflections, as a doctor. You work with residents and medical students, and of course your peers that are, MDs. What is that typical engagement? I don't know how much they even teach about emergency management or disasters in a medical school setting. And certainly when you're in your specialty, I'm sure you're very, very busy and don't have a lot of time to think about it. But what does that engagement kind of look like from a medical doctor side of the house?
It's great. It's great that you bring that up because there's really very little in the way of education for people that are involved in medical education, people that are interested in disaster management, disaster response, or emergency management. I mean, I really learned kind of things on the fly during my Katrina experience and then really sought opportunities out as a result of that experience. And what we're seeing is there's more and more interest, and it makes sense given the fact that we see more and more disasters occurring across our country and across the world. COVID just kind of bringing home, the importance of this work. And so what we're seeing is more and more trainees that are really interested and invested in learning more about this. But a lot of that education isn't embedded in their education. A lot of those pieces aren't really embedded in the curriculum per se. So when you look at my field, for example, pediatric emergency medicine, there are some questions on our board exams that are disaster related. primarily looking at disaster triage, allocation of scarce resources, things like that. But by and large, in a general pediatric setting, there's not a whole lot in the realm of disaster medicine education, and definitely even less when it comes to emergency management specifically. You know, it might be things that are very clinically focused, like dealing with nerve agents or, you know, outbreaks or things like that, but it's not to the degree of the kind of work that James and his team does. That's actually a gap that we've recognized here. So we've actually just this year started a disaster medicine elective for residents and fellows to partake in. We piloted a couple of months ago. And the thing that's great about it is we really think we've worked a way out where we can do it completely remotely. You know, just in the COVID era, remote is everything. And so we've really built a curriculum that involves introductory FEMA courses and other things that you can do online, modules that we have people do, things that we have people work through. And then we do weekly touch points where we have people do presentations on what's happening in their own institution if they're not at Texas Children's. We've already got a bunch of residents signed up for this year. So we're excited to see how it goes. And there's definitely the interest there. So I think you really pointed out a gap that exists for sure.
Yeah, well, and we've known about it obviously for years, and I guess you get exposure to some of this if you choose to spend some time in an emergency room or maybe an ICU, but it seems like the general practitioners out there, they don't ever really get the exposure to this, and that's totally understandable. There's so much learning that has to occur, but in a time like this, when we're in this era of this ever ongoing pandemic, I mean, most disasters, as you point out, I mean, Katrina, as horrific as it was, 9/11, as horrific as it was, they have starts and stops, and it's not 9, 10, 11 months a year as we're, you know, rolling into here with coronavirus. So I'm curious kind of too, James, in your planning and in your execution here of coronavirus, it would seem to me, if you've got all this great buy-in from senior leadership and got all these connections across this whole organization, has ICS been used as a way to kind of remove some of these existing barriers and get some stuff streamlined and be able to take some action?
No, absolutely. I think our use of incident command over the last 5 years has evolved considerably. We are very, very adaptable and agile in terms of implementing the parts of incident command that we need to respond to the specific incident. We started at the very beginning of the year with a half citywide water outage that took out water to all of our main campus buildings. So the largest part of our operations lost water pressure entirely for several hours. And we are so rapid with our implementation of a modified incident command that we literally had all of the decision makers together on a call within minutes to start making operational decisions. And everybody knew their role, they knew their place, and they knew the things they needed to accomplish as a part of incident command. And so we're really good when it comes to a hurricane of setting up everything we need for incident command. We know how it needs to operate, and we're very effective in that regard. But when you go all the way back to the beginning of our COVID response, we had what was called a COVID-19 task force. Well, we called it a task force, but guess what? It was incident command. We were using all of our incident command principles and procedures. We then moved into a full incident command response for COVID-19 response for many, many months after that. And as our response began to wind down, we then began to stand up another group of people that were going to look at redesign and a phased reopening approach to how we were going to get our operations going again in the new normal. So they didn't call it a command center. In fact, they didn't want to call it a command center. But guess what? That was all incident command principles, again, with an incident commander and all of the relevant roles filled. So I would say that incident command has been absolutely essential in our people knowing how it works and knowing what their role is in that process to making us effective.
Well, it's certainly exciting to hear, and you know, some of the things that you're able to do under the ICS structure, maybe a little bit easier than a normal everyday environment. I know a lot of folks have switched to telemedicine and remote learning and Zoom meetings and all this, where seemingly before folks had been trying to do that for many years and couldn't get it done. So maybe there's some opportunity here, some of the streamlining with ICS and of course the nature of this emergency that we're in.
Well, see, that's what was fascinating about our incident command response to redesign and reopening. Telemedicine was a huge issue. And as many of your listeners know, there's all sorts of barriers, whether it's language barriers, technology barriers, process barriers to getting telemedicine implemented and to getting it done quickly. Well, by using incident command methodologies, we had a limited number of people who were responsible for making decisions and allocating resources. And so what ordinarily would have taken us months to accomplish was done in weeks or days. So absolutely essential.
Well, we like
I
that.
think that's the key. Oh, sorry. I was just gonna add to that. I mean, I think it's a key point. And there's many examples that we could give you of situations where decisions that would have taken months, I mean, it's a big ship to steer, and decisions that would have taken months to kind of work through the proper channels to make those decisions happened in minutes, literally in minutes, in our incident command structure. And it's exactly why incident command works, right? You have the people in the room that need to make the decisions and have the power to implement those decisions once they're made. And we saw that many times over the course of in particular, our phased redesign and reopening command structure.
So, Brent, as we think about other disasters, and we're seeing it all over the country, wildfires, mass shootings, very active hurricane season. In fact, you guys in Houston got lucky. You didn't get hit too bad from that last hurricane, but certainly got some impacts. What does that all look like now, kind of under this coronavirus lens? How do we know who essential personnel is, and how do we prepare for hurricane? How has the landscape kind of changed in this environment that we're in right now?
So there's kind of two parts to this. One is kind of the positive, and one is all the extra work that needed to be done. And the positive is that, just to James's point, the fact that we've been in incident command for 6 months, it just means there's been more and more, I think, clinical exposure to what incident command is. So we've had more and more physician leaders embedded in incident command than ever before. It can't just be one or two people, drudging through this for 6 months. We've had to, have different teams, different clinical leaders, really embedded at the highest level in incident command. And so I think they've really realized what it means, what emergency management does, what incident command looks like, the power of that tool and that structure. And so when it came time for us to kind of prepare for Hurricane Laura, I would say that it was one of the smoothest kind of prep pieces to a weather event that we've had in a long time. And I really believe it's because of that physician engagement that's really built up and become stronger over the course of the COVID pandemic, which I think can't be discounted. I think we do a good job of embedding clinical leaders, but we're talking at the highest level of our clinical leads. Those people were in the room for months during COVID operations and really got a sense for what it looks like. I mean, the downside to preparing for something like a hurricane specifically in COVID is you have to really restructure a lot of the way you're looking at things. In particular, one of the things that what we do when we have a storm brewing in the Gulf is we enact what we call our ride-out team. And that's people that we bring into the facility. We have them in place to provide care and continue to provide care that we would normally provide under normal circumstances throughout the duration of the event. So we're kind of a self-sufficient island of clinical care, and those resources are in place. And when you think about it, you can't sleep people the way you would normally sleep them. You can't have a conference room with 25 people in cots right next to each other like you would pre-COVID. So you had to restructure, in particular, sleeping arrangements for everybody. Really, that drives needing to limit the number of people in general, because you'll realize you'll quickly run out of space for people to sleep. So really honing in on who is essential. And so I think those are the things that emergency management has worked tremendously hard at even before the hurricane season started, to try to tease out some of those plans and tweak the plans that we already had in place. And they've done a tremendous job at building those plans out. And then with Hurricane Laura, we kind of got to test those things. We were very fortunate that we did not get hit by Hurricane Laura or really significantly impacted. And we were able to see what worked and what didn't, and again, it was kind of, we always have too many people because everyone wants to help. And we had too many people, but we were able to kind of find sleeping arrangements for everybody, safe sleeping space for everybody, and work through that. And I think, again, some of those things just went so smoothly because we've been in that mindset of incident command for so long.
I think it's
kudos.
The point that you're making there, Dr. Kaziny, is it was interesting that we had more people than we needed. Vastly more people
Yeah.
showed up to be there on Ride Out. And in part, that I think was the result of the fact that we've done a lot of work to make people comfortable with the fact that we've taken the relevant precautions. We're still going to do health screenings. We're still focused on social distancing. We've got additional cleaning of various areas that was going to occur during Ride Out. We were very clear to people, if you come here for Ride Out, we know it's tense, we know it's stressful, but we're doing the things to ensure your safety. And so again, we had vastly more people than we actually needed to carry our operations.
I mean, thinking of every detail, even like if a worker, if a healthcare worker gets sick during Ride Out, develops symptoms, fever, cough, congestion, what do you do with them? So we had pre-designated areas where employee health would quarantine them, test them, see what needed to be done to get them either back in the workforce or keep them in place until the storm had passed and they were able to go home or wherever else they needed to go. So I think those are just so many of the multifaceted things that needed to be looked at during kind of hurricane preparations during this pandemic.
Let me highlight one more thing that Dr. Kaziny was talking about just a few minutes ago. The physician partnerships that we've developed that, from my perspective, didn't really exist have been phenomenal. Whereas in the past, as Dr. Kaziny said, there might be a couple of different physician lead roles within our incident command. As we've worked our way through COVID response, the question always at the table is, who's your physician partner for this? If you're putting together a work group to solve a problem, who's the physician partner who's going to have that kind of physician involvement, engagement, and perspective that we've never had before? And so now, as we're looking at other types of things, such as hurricane response, that's been embedded in how we operate. What do the physicians need? How do we engage them to get their perspective?
Well, and hopefully that's something now that'll be, systemic going forward, and we don't lose that in after this coronavirus is done, whenever it's done. But I can only imagine the richness that brings to the team, and we all know that multidisciplinary approach, it's really the way to go, because now we're looking at it from all different angles. And of course, at the end of the day, we want to support our healthcare providers that are actually laying hands on patients and doing the healing. So very, very good. Are there plans, or has anybody thought about kind of how to continue that on and continue that engagement, James, or how is that going to look going forward?
Well, I think it's a cultural mindset, quite frankly. And I think our experience over the last few months has really embedded it into our culture to ensure that we're reaching out to our physicians and engaging them. Quite frankly, when you talk about culture, the relationship that Dr. Kaziny and I have developed in how we operate the Emergency Management Committee, how we involve each other in one another's activities, it's that kind of engagement at that level and at the executive level that really, I think, has become a part of who we are.
Yeah. I mean, I think we've tried to at least model what, that ideal working relationship is of administration and clinical through the work that we've done with the Emergency Management Committee. And we've been pushing this for years, even before COVID. Just COVID was a great opportunity to get it in place. But we've looked at, doing things to just further that engagement with physicians and embed them even further than the occasional doctor that shows up to the Emergency Management Committee, but really thinking of a substructure of physician leaders that are interested, have a personal passion for this work, because we're seeing more and more people do, and getting them kind of boots on the ground to work with us on this stuff.
So James, as we think about, the winter and second wave or third wave or whatever kind of wave may come our way, hopefully it doesn't, but if history is any indication, maybe we'll see another spike here in the fall and the winter. I'm going to ask it two ways. So for James, what are the operational incident command type things that you're thinking about now to sustain this effort? I know folks can maybe get burned out, may get bad again. You may have supply shortages. And then for Brent, from a clinical standpoint, what are you looking at for this fall, this winter? How can we drive these numbers down? What creative things are you doing to make sure folks are still getting, immunizations and the flu shot and all that? So I'll go to James first, and then Brent, if it's okay, I'll ask you to talk about some of the clinical stuff you're thinking about.
So the message that we have delivered clearly to our organization is although everyone is focused on COVID, don't forget the basics. We still have to be prepared for hurricanes. We still have to be prepared for civil unrest. We still have to be prepared for active shooter, chemical decontamination, all of the things we would ordinarily be prepared for. We still have to be prepared for those things. Those things can't be pushed aside because the likelihood of them occurring hasn't lessened just because we are responding to COVID over the last several months. And so the key element is don't take your eye off the ball. Remember that your people are tired, they're exhausted. Fatigue is not too strong a word to say regarding what your people are feeling, but understand that we cannot lose our focus. We can't lose our intentionality in doing the things we need to do to be prepared. Because remember, even in the midst of all of the other things that we are looking at, most hospitals are also struggling with a financial crisis. And in the midst of all of that, we still have to do the things we have to do to be prepared. So that means looking at our response during Hurricane Laura and doing our after action report and ensuring that we've learned the lessons we needed to learn. It means doing our after action report around our response to COVID and making the improvements that we need to make. Again, doing all of those things, no matter what else may be going on around us. Don't forget the basics.
Super. Brent, what do you think from a clinical standpoint?
Well, I think, from a disaster response or kind of pandemic, more global situation, we really early jumped on surge planning as an institution and developed, I think really well thought out and embedded surge plans for our emergency centers and for our pavilion for women should we have a large influx of low acuity patients, because we know hopefully, children are less impacted by this illness, and hopefully we wouldn't see a lot of sick kids, but more large volume of kids coming in with fever, cough, congestion. Parents are wanting them tested for COVID or what have you. And so, at this point, we did that really early. I mean, probably too early, but we did it, and we built those units out. They're deployable or still sitting in place in one situation. And so I think one of the things that we need to think about is, again, like you said, James, not to take our eye off the ball of this thing and realize we may need to use those units. We've built them, we've set up all the systems, we have them very easily operationalized, but we got to revisit it because it's been a while. It's been months since we really did that legwork. And so I think we need to dust it off a bit, relook at it, see what we need to do. But I think to James's point, it's fascinating kind of the financial impact that this pandemic has had on hospitals. And it is definitely a situation where you can't just throw a ton of resources at things. We've had to be, I think, very particular in the way that we approach what our expenses are on this. And so you don't want to just build these amazing units that are maybe going to sit there empty. You really have to think about what your system trigger should be, when you would want to open these things up, when you would want to go there and do that. So I think that's part of kind of on a global scale. And I think it's really about the simple stuff from a clinical perspective, right? We want to try to limit this winter's effect and impact on children in general by promoting flu vaccines, doing those simple things that we should be doing every year, but better. What that drives home for me is, I really think about personal protective equipment. Huge issue early in this pandemic. We've been very fortunate that our people in logistics and supply chain, I think, are top notch in this respect and have done an amazing job of getting us all of the personal protective equipment we could possibly need. At least we think at this point. I think they'll continue to get it if we need more. But I think to normal winter months, during the flu season, I, as a peds emergency medicine doc, going into a room with somebody with influenza-like illness, I'm supposed to wear a gown, gloves, and a mask. Do I usually do that? No. Do my colleagues usually do that? No. We kind of have gotten just so used to not really doing what infection control has been kind of dictating to us over the years, because we're just, you're just running and gunning and you're taking care of patients. And so I think if anything, what it's done is it's brought back to the forefront the things that we should probably have been doing all along, but didn't do very well. And again, it's kind of embedded that into our response, not just as a result of COVID, but just more globally what we should be doing from the beginning. And we're doing it. So I think those are all some of the clinical things that we can be focusing on moving forward that I think are going to hopefully make this winter, not some horrible event. I'm very hopeful that we'll have a mild flu season. because of all the other things that we're seeing happen in our society, social distancing, mask wearing, all those things are going to help with flu too, right? I mean, we know that. And if you look at the Southern Hemisphere, they've been having a mild flu season. So fingers crossed that stays true for us as well. But it's just about doing the things that you know you should be doing, you know? And so I think that's what it really comes down to, is just keeping that up. And to James's point, it's tiresome and it gets old and people get run down. And so I think it's watching your peers, watching your colleagues, making sure that they're doing what they're supposed to be doing. And so I think just embedding that into the culture is really important as we move into the winter months.
Well, and I know there's been some creative solutions too about, drive-through flu clinics and drive-through immunizations and even drive-through, prenatal visits and stuff like that, right? So maybe some of that stuff will stick around after the pandemic. I certainly think from a infection control and a public health standpoint, those make a lot of sense, just like wearing gowns, washing hands, all that basic stuff, right, Brent?
Yeah, I mean, one of the things that has been a key focus for us is not just making sure that our clinical environment and our care areas are safe for families to come into, but also making families feel safe with whatever we're affording them the opportunity to act, however we're affording them the opportunity to access care. So ramping up telemedicine, tremendous ramp of telemedicine, drive-through specimen collection sites for COVID testing, curbside immunizations, like you mentioned, drive-through prenatal visits. So these are all things that, we think we could probably safely bring people into the institution to keep everybody safe, but, it makes everyone feel safer, one. Two, it eases the access, which is a huge issue in healthcare to begin with. Improving access to healthcare it should be kind of on everyone's forebrain, and we're just doing that as well. So I'm very hopeful that a lot of these initiatives are going to be here to stay for a long time in the post-COVID world into the new normal. And a lot of those things were capable of happening because of the rapid way we were able to engage and respond due to incident command.
Yeah, I think that's really the big point. And this is a pivotal time in history. I mean, we know these big events, the Katrinas, the 9/11s, the pandemics, they drive change. And I think, the folks that keep saying we're going to go back to normal, yeah, maybe to some degree, but James, I see you shaking your head. It's not going to be normal as we know it. This has went on for, almost a year now. Things are definitely going to change.
No, I agree. Things are going to change. And, as Dr. Kaziny was saying, there's so many things that we have learned that need to be operationalized and maintained for the long term, because we've now had to make investments in technology and investments in ways of operating that would have ordinarily taken us years to do. We've done it. Let's embed it. Let's live with it. But also the things that have been developed around surge plans and maybe alternate supplier plans to make our supply chain more resilient. Those things need to be maintained and included inside of our emergency operations plans. Don't take all the things that we've spent months learning, sometimes learning the hard way, and lose all of those things for the next generation of people that come after us. Learn it, embed it in your emergency operations plan, train to it. Don't step down from the hill that we've climbed.
That's a point I actually brought up in a meeting just the other day with regards to our drive-through testing sites, our drive-through specimen collection sites. There's been a ton of work on operationalizing those and getting those where we can see 500 plus kids a day and get samples for both employees and patients. And in 10 years, the people that are operational leads for that right now might not work here anymore. And this is where I think emergency management plays that great role of putting that into a plan that can be accessed for the future if this is something that we don't need in a year, but maybe we'll need it for the next pandemic or the next, X. And they'll be able to say, oh, this is how they did this. I mean, our experience with the surge units that we put together for COVID in the kind of early days of the pandemic is a prime example of this. Something that Texas Children's has done very well in two historic pieces. One was during H1N1, and one was during the evacuees in the mega shelter at the Astrodome. So we started something that we call our Mobile Pediatric Emergency Response Team. In the Astrodome, Reliant Arena Complex took care of thousands of kids that were displaced that didn't have a medical home. during H1N1 saw hundreds of kids without having them have to come into the facility, access the building, all these other things. But when it came down to us putting these plans together for COVID, it was kind of like a piecemeal, well, there's this plan from 10 years ago that kind of has some of the stuff. There are these documents from some of the leads from the emergency center has this kind of stuff, but there wasn't really like any one unifying document that captured all of the knowledge. And some of that we had to lean on institutional, historical perspective, because we're fortunate that a lot of people that worked on putting those things together still work here. But if that had been lost, where would we have been starting from scratch? And that's not where we want to be. We want to have that plan. We want to be able to mobilize things quickly, get things done. And so that's, I think, a great role that emergency management has in taking all these things that we put together specific for the pandemic. And when they do, hopefully we don't need a need for them and they go away. But for whatever comes next, we'll still have that, robust plan in place.
Yeah, you think about all the time and effort that local health departments have spent on, points of dispensing for anthrax and all sorts of other things. There's really some lessons learned here from the work you all are doing, the drive-through clinics, the drive-through testing, and of course, at some point in the future, the drive-through coronavirus vaccine that's going to be coming. Now, whether that's 1 shot or 2 shots or 3 shots, whatever that's going to look like, we're going to have to be asked to stand up some stuff to get that out to the public as well. So a lot of great work, a lot of great lessons learned, certainly a lot of creativity, I think, during this time of, unprecedented public health emergency. I'm curious, James, and I'll just draw on my own experience when I was working with so many wonderful, really top-notch emergency management folks at the hospital setting in Indianapolis when we were preparing for the Super Bowl. Fantastic people, wonderful, smart, on top of their game. But I always kind of chuckled. Most of the time I find them relegated to a basement office. Nobody knows they're there. They're doing incredible work. Doesn't much get outside of the basement though. I'm hoping that this opportunity and all the wins and all the value that's been added and shown can kind of break that mold. And I'm wondering, James, if you have some advice to your other colleagues out there throughout the country that are listening to this saying, wow, these guys in Texas, they figured it out. How the heck can I get started here in my organization?
So one of the things that I would say is absolutely essential, and I've seen this on the emergency management side as well as seeing it in the business continuity side, is there is a difference between somebody who just writes a plan versus somebody who has a seat at the table when things are going south and those plans need to be operationalized. And because of the relationship we have with our senior executives, because we are a critical resource for our administrator on call rotation. So that's a rotation of executives that rotate in and out every week. And by default, that person is the incident commander if something happens while they're on call. And so we support them across a range of incidents. Every one of those executives knows every member of my team by name. We all are in each other's cell phones. When something is happening and they need information, they are texting us, asking us to gather data, to hand them data, and then to let them know what kind of plans we have in place and what have we done historically responding to different kinds of incidents. Because when something happens, we're in the room with them, whether it's virtually, on the phone, or actually physically. We have a seat at the table. And if an organization does not have an emergency management or continuity leader who has a seat at the table, the organization is missing a huge opportunity. But also from the perspective of the EM professional, you're missing an opportunity if you've not made yourself valuable in that way. So be there when things are going bad, be the answer to people's problems, and that is how you get a seat at the table, and it's essential.
I mean, it's great advice. It's sad to see so often that folks are just relegated to know JACO or know the Joint Commission. That's what your role is. Make sure you meet these requirements, or CMS, Center for Medicare, Medicaid. Meet those requirements. That's all we're asking of you. I think that's really an antiquated view of emergency management. I think it really misses the point of the value, the networking, the connections, the strength that it can bring to an organization. And I got to tell you, I love your title, Director of Organizational Resilience. What a fantastic title. I don't know of too many health systems that have that title, and maybe I'm missing it, but I think that's a fantastic way to brand this. And it certainly sounds a lot better, and it makes me stand at attention when I read your title and say, wow, this guy's this guy's somebody. I need to know this guy.
I appreciate that. It's like I said, it's absolutely phenomenal to have an opportunity to be a part of an organization, which to a degree, I inherited a tremendous culture when I had walked in the door. The culture of preparedness, the culture of emphasizing the importance of being prepared and doing the things we need to do. Whenever I brought in the message 5 years ago that regulatory compliance does not equal preparedness, everybody shook their head at me and went, that's right, it doesn't. It wasn't a huge fight to get a lot of our leaders to understand that. They believed it. And so it was just a tremendous opportunity to work with people that already had that mindset. If your focus is just meeting your regulatory requirements, you are not a prepared organization. Preparedness is far beyond that.
Yeah, no, I think that's 100%. And of course, we all know the regulatory requirement is the floor, is the baseline. And I'm not the kind of guy, I know you two aren't the kind of guys that like to do the bare minimum. We want to go above and beyond because we know how important it is. Brent, as we're thinking about lessons learned or success stories or advice you may have for others, what comes to mind in your neck of the woods?
I think kind of just hearing some of James's comments in the last couple of minutes here really struck home that, Texas Children's has always had a great culture of preparedness. And that's why, I think what brought James to the job. It's definitely what brought me to the job here. It's already there. And I just think the key thing that we've been kind of echoing throughout a lot of this, and I think it's just the big lesson learned, is, and it sounds just cliche because it's what you hear every time there's a disaster, but communication is such a key piece to this whole thing. And you can't communicate if you don't know people, right? So it's about building that network. It's about just what James was saying, building that network of administrative leads, of EVPs, of high-level executives throughout the organization and institution. But it goes beyond that too. And I think if there's anything I hope has happened as a result of this COVID pandemic and everyone being embedded in some way, shape, or form in something like incident command, is that they've recognized that physicians tend to be siloed during these things, and to just further build that relationship with their physician partners. That's something I think since James and I started working together in this, we recognize the value in our relationship. And it's a whole other network that a lot of times emergency management doesn't get exposure to, or emergency managers don't get exposure to, is that really the clinical leads, the physicians that are taking care of patients and that are medical directors for their section or what have you, that really have the knowledge to bring to the table. How do you deal with a surge of patients? So taking it from that theoretical to practical, taking that plan from a joint commission check the box to something that you can actually take off the shelf and use, unlike a giant 500-page binder that no one's going to look at, that you need some sort of clinical input for that. It's impossible for it to work without some sort of a clinician assisting you shoulder to shoulder and looking at it. And we get it. James and I get it. And that's why we like working together. And that's why we've, I think, had such great time working through many of the challenges that we've had over the last 5 years, and we've had the successes that we've had. I think that's a key to it too. It's not just about meeting the EVPs. It's about meeting the physician in chief, meeting the chair of pediatrics, meeting the chair of surgery, just walking through the hospital and just meeting people. It's harder now, obviously, with COVID. It's harder now to get that face time. But I think once this is said and done, it's really about getting out there and meeting people, learning what these people do and how they work, and building that network. And we're fortunate because it's kind of like it's kind of like two arms, right? I'm networking with the physicians. James is networking with the execs. There's obviously crossover that occurs because we introduce each other to people and things like that. But I think that is a real key to success if you're doing this job, is reach out. There are physicians that have lived through, some of the horrific things that have happened in this country in the last, decade, and they probably have a passion for this work. But, they might be a pathologist. They might be a radiologist. They might not be somebody that you would think of as being interested in disaster response or emergency management. Find those people and bring them in as your partners in this thing, and you're going to be successful.
So it's kind of in the weeds, but just I'm curious, if I'm a nurse, a doc, or whatever, working on a med surg unit, how am I funneling up into your system? How am I able to give that feedback? Hey, I'm running out of gloves, or whatever the feedback is. How do I funnel that up so it actually gets to the right people in the ICS structure?
So within the ICS structure, obviously we are configured such that we have an entire logistics section. And what we try to do is we try to leverage existing processes. So there will be a supply chain number that people can ordinarily call in order to get supply needs met. Well, they can continue calling that same number, but the people who actually take that call, they know that this structure is in place to which they can escalate the concerns that they have. And so once we get that structure up and running, everybody understands that if we're losing a critical supply and we're running short on something, quite frankly, the people on the front end, they're going to be the last people to, I think, be aware that we're short on something, because our supply chain people know what we have and they're monitoring the burn rate. And so if we run out of it on a unit, they're already aware of any kind of supply chain issue that may be causing them to have run out of it on the unit, or maybe they just need to deliver more. So again, trying to leverage what already exists.
Yeah, that's great. I mean, I really think the systems that work well kind of overlay on top of what works good day to day instead of blowing it up and starting all over. So that's really interesting. The other thing, James, and boy, I mean, I think everybody sees the need for an after action report. I don't want to be the one to write it, but in a situation of this long of a duration with so many different challenges, how are you handling capturing the data and doing it? Are you doing like mini after actions, or how are you approaching that?
So what we have done, particularly for COVID, is we're looking at the time period where we had incident command activated in a response mode.
Okay.
And we're after action report specifically to look at what did we do during the response phase. But the interesting thing is, when we shifted over to a phased reopening and redesign command, that group was actually addressing a lot of the things that are in the after action report. And so I look at the work they did to say, okay, what issues did they address? Those are clearly issues that need to be in the after action report. And so these two things are working together very nicely for us as we develop that after action report. But you hit on it very, very importantly. You've got to assess what you did. You've got to assess how you performed. You've got to assess, determine what your corrective actions are, and then trace all of those things through until they're done and they get embedded. If you don't do an after action report, you're losing all of those tremendous lessons learned, and you're missing a huge opportunity.
And you're not getting the credit for the tremendous work that you did, right? I mean, it's a very important thing, right? I mean, you can't do a great job and then at the end everyone say, oh, that was a great job, but I'm not really sure what James's team did. You have to be able to say, like, these are the things that we did. I mean, you have to be able to take credit for the work that you did and accomplished. That's what gets that buy-in that I think emergency management here has at that, organizational resiliency has at that level at this institution. Is not only have they been in the room when things go south, they're able to say, this is all the stuff that we accomplished. These are the deficits. These are the things that we're going to work on making better for next time. And then they show that they were better the next time. You've got to show that progression to prove, I just say prove your worth, but in this day and age where, again, financial burdens on hospitals, secondary to the pandemic, people kind of tightening the belts, you've got to be able to show your worth. It's a very important thing to do.
Well, and that's easy to get lost, as you know, in the heat of battle with so many other competing priorities. I do feel like we sometimes forget how important it is to show what's happening, what we've learned, and why we did what we did, and all that. So I guess having a good scribe or someone capturing that as you go about is always a good idea. And then I suppose, I don't know, weekly, monthly, whatever the time frame is, taking time to download, step away from the situation, and really reflect on where have we been, where are we at, where are we going. We always hear that, great adage, as soon as you begin mobilization, you got to start thinking about demobilization, and what does that look like? So I think that's very good points, well taken. And yeah, there's going to be a lot of fantastic lessons. I mean, you guys have shared some already today, but think about all the knowledge gained, think about all the new systems that have been put in place, think about the great successes and some of the failures that have happened that we should really all be trying to capture and learn from. How can folks stay on top of what you're doing? How can folks learn more about Texas Children? What's the the best way to stay abreast of what's going on there in your organization?
Brent, we'll toss that over to you. You've got some good resources, I think, that you can share.
So dependent upon the audience, I think there's a lot of access to a lot of different, things that we've done. Obviously, you can look at Texas Children's Hospital's website, and there's a number of resources specific for coronavirus that we've compiled there that I think are very helpful to individuals outside of our organization. One of the things that we've always been very open about too is just sharing the work that we've done. And I think that, again, is kind of taking emergency management at an institution to the next level, right? It's not just about having a great plan here, but it's about saying to everybody else, like, hey, you don't need to build a family reunification plan. We have put one together that I think is phenomenal. And so we are very willing to share those plans with us. We love it if we get a little bit of credit, obviously. It's nice to get credit for the work that you've done. But we've, through some of the work that I do outside of the institution, we've been able to, I think, get some national recognition for some of this work that we put together. In addition to the work that I do here at Texas Children's, I'm one of the co-directors of the disaster domain for EMS for Children Innovation and Improvement Center. Their website has a lot of resources specific to disaster preparedness. I think it's a great place to go for some of this information. And we've put together, through that, 2 maintenance of certification projects for physicians that are interested in disaster preparedness. One for clinic-based providers, just like you mentioned, how many clinicians in private practice are out there really preparing their clinics. So we've put some things together where they can get credit for their maintenance of certification. They can work through a 6-month kind of plan and really beef up their disaster preparedness. And then there's another one that's kind of the partner to that is for hospital-based providers that are similar to myself that work in a hospital system that are trying to do something similar, along with some, national quality improvement initiatives looking at improving the care of children in disasters. And so a lot of the materials embedded in those programs are things that I've taken from our emergency management group here. Copies of just a form of our after action report. Here's an example of a good after action report, a blank form. We've used our family reunification plan as an example of a family reunification plan that people can use. It's frustrating to see people spinning wheels and reinventing the wheel when there are already so many great resources out there. And that's what we try to do through both the EIC's website and just through our openness and willingness to share some of those resources.
And so,
gentlemen,
Dr.
go ahead. I'm sorry, James.
There is everything we've developed, we are more than happy to share. We have done a wide range of large-scale, multidisciplinary exercises from active shooter to mass casualty, involving multiple external agencies, large-scale cyber exercises, radiation injury treatment network exercises, a wide range of exercises. And we don't hold that stuff as if it's some sort of proprietary knowledge that nobody else should have. As Dr. Kaziny said, if we have a plan that we've developed, if we have an exercise process that we have put into templates that we can share so that people aren't starting with a blank page, we are happy to share that with anyone who is interested.
And I think coming from, the world of academia, as a Baylor College of Medicine employee and assistant professor, we're all about doing presentations, doing poster presentations, publishing. And I see the tremendous work that, James's group has done at Texas Children's and the Texas Children's has done. And there's just not that impetus to get that stuff out there in the same way. And so I think we've done better at that. And I think that's something else that I'm also very proud of, is that we've been able to have, a number of posters and presentations at national conferences that are either disaster related or pediatric focused on some of the work that we've done. Because these guys, I think the emergency managers out there should be getting credit for the great work that they're doing beyond kind of within their institution. They should be getting more global credit for the tremendous work they're doing.
Well, thank you, gentlemen, very much for joining us today. I've learned a lot. Great work down there in Texas. Keep up the wonderful work. I'm glad to see that you're doing well and you're both still smiling, so that's a good thing. I hope everybody at home has enjoyed this podcast. Just a reminder, we have a whole host of podcasts over at the Domestic Preparedness Journal. You can go to domprep.com/podcast and access them all. But for everybody listening, please stay safe out there, stay healthy, protect yourself and your family. And this is Andy Roszak saying, I'll see you on the next Domestic Preparedness Podcast. Thank you.